All right, we're back now. We're going to bring on our next presenter. That presenter is Evan McNamara. Evan's a pharmacist at Home Care Pharmacy, a family-operated community pharmacy serving the Beloit community. His pharmacy interests include medication therapy management, polypharmacy, and geriatric care. Welcome, Evan.
Thank you for the introduction. Hello, everyone. I hope everyone is doing well today. I'm excited to talk about Parkinson's disease and the medications that are used to treat PD. I'd also like to give a special thanks to Pat Burhans, who got me involved. Of course, she told me there was only 10 people, but now there's 120 of you here today, so I think that's absolutely spectacular. So this is my first time giving this presentation, so I was really happy to learn some of the things more about this disease state, and I hope everybody can take away something new that they can use as well. So let's get started. I don't have any conflicts of interest to disclose. Just a little bit on my background. I graduated in 2017 from the University of Wisconsin, Madison, with a doctorate in pharmacy degree. From there, I went to work for my family's community pharmacy, Home Care Pharmacy, which is now affiliated with Hometown Pharmacies. So our pharmacy does a lot of medication packaging for different assisted living facilities, which is where I'd see a lot of the treatments that we currently do for Parkinson's disease. So what we're going to talk about today is going to be kind of the who, what, where, when, and why of Parkinson's disease. We're going to see how the medications work, kind of main side effects to look for, and also some common drug interactions. And then I'm going to take the end of the presentation to kind of just quickly discuss some of the emerging treatments in treating Parkinson's disorder. And we'll see what we can go ahead with. So to organize this, I went through the who, what, where, when, and why of Parkinson's disease. So we'll start with who. Parkinson's disease tends to affect both men and women. However, it seems to affect more men than women. So although pretty much anyone can get Parkinson's disease, it tends to manifest itself in older adults primarily. So when looking at the symptoms, I know Dr. Manjan talked about some of the non-motor symptoms, but when the classical representation of Parkinson's disease, tremor, slow movements of the extremities, rigid muscles, impaired balance, those are the main things most people think about when they talk about Parkinson's disease, as well as some loss of autonomic movements such as blinking, speech changes, soft slurred speech is also common. And then people also notice that they start writing smaller as well. So there's different types of Parkinsonisms, which are different than Parkinson's disease. So Parkinson's disease is its own condition. Parkinsonisms are a general set of neurological disorders that produce symptoms similar to Parkinson's disease. So those would be things that kind of produce the classical symptoms, you know, the tremors, slow movement, stiffness. I'm not going to go into too much detail on these different types of Parkinsonisms, but I will touch on the drug-induced Parkinsonisms. So those are usually caused by antipsychotics, calcium channel blockers, or stimulants such as amphetamines or cocaine. Generally, the effects of drug-induced Parkinsonisms can be reversed. So that's just one kind of thing to look out for when making the diagnosis of Parkinson's disease. So when looking at where Parkinsonism or Parkinson's disease is, so there's approximately 1 million cases in the US. Approximately 60,000 are diagnosed with PD each year, and approximately 10 million total cases worldwide. So the Parkinson's Foundation Parkinson's Prevalence Project kind of looks at the prevalence in the United States. So one thing I'll highlight is this data most recently shows that there's about 15,000 people living in Wisconsin with Parkinson's disease. And they're projecting out 1.2 million people in the US with PD by 2030. So it's relatively common, and it's important to kind of follow these statistics to make sure that we have an understanding of that. So most people end up developing Parkinson's disease around age 60. About 5 to 10% of patients with Parkinson's have early onset disease. And really, let's look at why this is occurring. So I think everybody kind of understands that Parkinson's disease is when neurons are damaged and are producing less dopamine or norepinephrine. That generally occurs in the substantia nigra, which is a portion of the brainstem. That's where the majority of the depletion occurs. It's about 10 to 15% genetic is what some of the information I found. And there's also some environmental factors. So I'm not going to get too much into the whole genetics behind how it happens, but they're looking at, there's a study called the PD generation study that's looking into the specific genes involved, and they identified LRRK2, GBA, and SNCA as the kind of the main genes that they're looking at. Environmental factors can also end up playing a part. So things like head injuries, toxin exposure, and occupation can all increase risk. So the odds of developing a PD are probably a combination of both environmental and hereditary, with probably hereditary being the majority. So this is kind of a map of where that depletion occurs. So basically in the substantia nigra part of the brain, which is located, hopefully you can see my cursor right in that area. So now I'd like to transition some topics. I'm a pretty lighthearted person. So here's a picture of my brand new puppy. I got him yesterday, 7 weeks old. So pretty darn adorable, but that's his morning breakfast today. So now into the meat and potatoes, the medication classes to treat Parkinson's disease. So there's a few different classes. So we're going to discuss in each of them in more depth. So looking at there's SINEMET, which is the main treatment, I would say, the dopamine carboxylase inhibitor, dopamine precursor. There's COMT inhibitors, dopamine agonists, anticholinergics, the MAO-B inhibitors, and amantadine. So we'll get started here with the main one here, SINEMET, which is available in both extended release and immediate release. So basically how this drug works is dopamine itself. If you just took a tablet of dopamine, it wouldn't be able to get into the brain where it's supposed to work. So get around this issue, they give out a precursor molecule called levodopa that gets converted by an enzyme in the brain to dopamine. So the carbidopa component allows for a higher concentration of crossover because of its inhibiting the enzyme that breaks it down. So basically, I'm not going to quiz you on all of this, how this occurs, but just know that the end result is that dopamine gets to the brain and works where it's supposed to. So some important things to know is that this drug, as I mentioned, has both immediate and extended release forms. So there are some very specific guidelines from switching between immediate release and extended release, basically in dosing interval. So immediate release has to be given more times per day than the extended release. But really the the titration of the effect is the most important thing for patients, because a big problem with really Parkinson's disease in general is that there are off periods. So when the drugs wear off and then the symptoms come back, which is a very common thing here with SINEMET. So the other thing I'd like to mention is that high-fat foods can also affect the absorption. They do recommend that immediate release be taken with food to prevent GI upset. However, just be aware of like somebody going and eating a big cheeseburger after, and then taking their SINEMET, then that can affect the onset of action. So, to kind of continue here, looking at side effects, I think Dr. Manjan also kind of touched on it, but when you give drugs that increase dopamine levels, you can get abnormal dreams. And that's something that is kind of just characteristic of dopamine. You think of the dopamine as the reward complex. So if you're trying to replace what is gone and you end up overshooting that a little bit, that's when you can kind of get those side effects. Also, I would mention that headache or GI upset, those are also kind of possible with SINEMET. So, kind of the thing I would tell people when it comes to drug interactions is to just think of how the drug works. So SINEMET replaces dopamine. So a lot of the mood leveling drugs like antipsychotics, things that can be used for bipolar disorder as well, those tend to try to lower dopamine levels. So if you were to take that with it, it would kind of cancel each other out. So just be careful with that. As well as some blood pressure lowering medications. So it's another, it's not too bad with SINEMET, but you can get, in addition to blood pressure medications, you can get lowering of blood pressure. So when you add a SINEMET with it, it's really important to kind of monitor those effects. And if you need, I'm not telling people that they should stop taking their blood pressure medication because they just took SINEMET. That's definitely not the thing to do. But one thing is that you should probably monitor your blood pressure. And if you notice it going lower than it typically should be, then you should consider maybe talking to the doctor and dose reducing your blood pressure medication or something along those lines to kind of manage that. The next class is CATECHOL-O-METHYLTRANSFERASE inhibitors. I didn't make up that name, but basically they prevent the degradation of levodopa. So if you keep that levodopa concentration high right over at the blood-brain barrier, that increases the likelihood that you'll get dopamine to the brainstem where it needs to. So basically the enzyme is called COMT. And the main drugs are entacapone, opicapone, and tolcapone. So they're usually used kind of as an adjunct to SINEMET for the most part. So yeah. Then looking at side effects, again, the blood pressure is an issue here. So orthostatic hypotension is what a lot of people notice. Orthostatic hypotension is basically when you get from seated to a standing position, you almost feel really lightheaded, like you're going to faint. Well, that's actually a decrease in your blood pressure, as well as mental status changes as well. And that's kind of coming from the whole dopamine level being higher, possibly overshooting. Drug interactions, when you inhibit an enzyme, you always have to look at what other things are metabolized by that enzyme. So epinephrine and norepinephrine are metabolized by COMT. So there's certain antidepressants that impact norepinephrine. The one that comes immediately to mind is venlafaxine. So again, I don't know if I would consider that to be a super contraindication, but it's something that definitely needs to be monitored for, blood pressure and mood and effectiveness. So. Then going on to dopamine agonists, so pramipexole, ropinirole, bromocriptine, apomorphine. Those are going to be the drugs that kind of mimic the action of dopamine. They're not dopamine, but they stimulate the same receptor, provide that same effect. Generally, it's a good idea to take them with a meal to prevent nausea. And they tend to have their own side effects as well. So constipation, nausea, dizziness, generalized weakness, and also the same thing goes with the blood pressure. So antipsychotics as well. So the anticholinergic medications, you can think of that as the trihexyphenidyl, benztropine, diphenhydramine to an extent has some anticholinergic-like side effects. They directly inhibit the parasympathetic system to relax muscles. So that's like your muscle and skeletal system. So the big thing with anticholinergics is that they have kind of more side effects that people find bothersome. So things like constipation, dry mouth can cause some confusion as well. So that's really important. I think some of those are actually listed on the Beers list of criteria of potentially inappropriate medications in elderly patients. So that would increase risks of falls. Those types of things are very important to look out for. The other thing, main drug interactions wise, and this is one that going back to how I kind of try to think of polypharmacy. You have a patient who has Alzheimer's dementia with Parkinsonism, and they're on drugs like Aricept, and you give them this, it might cause more confusion. Again, there's not like a perfect decision for some of these patients that might need treatment for both conditions. So that's just another thing that it always boils down to a real risk-benefit conversation. MAO-B inhibitors are, they're pretty, they aren't used all that much. They're a bit older drugs, but basically they're kind of like the COMT inhibitors. They prevent dopamine degradation in the brain. The selegiline is also available as a transdermal patch, which has some benefit for patients that aren't able to take oral medications. So when it comes to side effects, nausea, dry mouth, constipation, those are things to look out for. They can have a lot of side effects, particularly with antidepressants, because everything's kind of metabolized by this MAO enzyme. And basically when you inhibit that, you can create high serotonin levels, which can play around with a lot of the antidepressants. So you don't want to have too high of serotonin levels, because that can put you at risk for a condition called serotonin syndrome, which is it's a very dangerous type situation. So something that can be monitored, but something to also be aware of when going to prescribe. The last one I'm going to talk about here for like current treatments is amantadine. So the mechanism is kind of unknown when it comes to treat Parkinson's, but partial effects on dopamine neurons it has. It's a weak NMDA inhibitor, which is sometimes used in Alzheimer's medications like memantine or Namenda. It's also an antiviral too that can be used to treat the flu. They used to use it. I hardly ever see it anymore. And they're actually doing some studies about coronavirus with it, but I haven't really seen any true benefit or anything yet. Again, side effects kind of manifest themselves as anticholinergics. So same thing, dry mouth, constipation, urinary retention, can have that dizziness, orthostatic hypotension effect going from the seated to the standing position. And then the things to look out for is just kind of similar, Alzheimer medications, antipsychotics. So now I'm going to kind of pivot over here to some of the newer treatment options. You might have heard of a DUOPA pump. That is a continuous infusion of the carbidopa-levodopa in the form of a gel into the GI tract. It requires a tube to be placed and the cassettes to be changed daily. It has very similar side effects to SINEMET. It's kind of sudden sleep and depression, though, is kind of a different differentiating effect to it compared to SINEMET. But again, when it comes to off time, because if it's the cassette provides the infusion, it kind of helps with that. And then another strategy is deep brain stimulation, where they do brain implantation that provides electrical impulses. I would say both of these are kind of more so reserved for kind of advanced Parkinson's patients. So, well, it wouldn't be 2020 unless I brought up medical marijuana as a treatment for PD. So how it works is that the CBD and THC activate endocannabinoid system. This system tends to cause some relaxation when stimulated, which is postulated as having an effect for treating tremors. Their literature out there kind of varies. Some of it supports medical marijuana as having a truly beneficial effect in PD. And then there's other research that kind of shows that it doesn't have an effect. So really what I would tell people is to, again, have this risk, cost, possible benefits of deciding to go down this route. So the benefits would be possible improvement in anxiety, pain management, sleep dysfunction. If you're noticing weight loss, it could help improve that, and nausea. So really, because of there's two components, the CBD and the THC that's located in marijuana, the CBD tends to be non-psychoactive and the THC is psychoactive. So when treating with medical marijuana, the thing with the THC is that it can cause, altered mental status, behavioral changes, loss of balance, and sometimes, pretty rarely though, hallucinations. So ultimately, it's something that, wouldn't be a bad option as being brought up as part of the care plan, but it's likely insufficient treatment as like a solo regimen to treat Parkinson's disease. Now on to the last little exciting part I have here, sort of the new treatment methods that are being investigated. So one treatment that has shown some promise has been stem cells. I know it's a very controversial topic on ethical grounds. However, this treatment is basically taking precursor cells and putting them into a different environment that allows them to differentiate into the desired dopaminergic neurons. So it's kind of cool because it's restorative to Parkinson's disease. However, with everything, there always seems to be a drawback. And in this case, when you're taking these precursor cells and putting them in a growth medium, it can actually cause risk of creating tumors and cancer. So that is one of the possible risks. The next treatment is viral mediated gene therapy. So for the record, before anybody can ask, there is no relation to the novel coronavirus in treating in this type of gene repair mechanism. However, basically the gene is carried within a virus, and the virus, attaches itself to the cells and injects the DNA or RNA into the cell. And that DNA carries the proper gene to restore the dopamine function in those neurons that are damaged. However, there's always a cost, and when you are inserting and replacing DNA and RNA, the enzymes that do that have an error rate, and sometimes they have mutations, and those mutations can then cause tumor formation or cancer. So although both of these strategies are pretty interesting because they can restore function and possibly reverse Parkinson's disease, they do come with a risk, and I think that it's something that they're going to have to hash out the details before they deliver a finished FDA-approved drug. So in conclusion, Parkinson's disease is complex to both treat and manage. Really, there's a lot of different comorbidities that patients have, like high blood pressure or Alzheimer's disease, and or different mood disorders that when you start adding medications to treat Parkinson's, you run the risk of interfering with those other disease states. I think eventually, we're going to find some improved treatments for Parkinson's disease, which I think is very, hopeful. And I think it's something that we can all look forward to, is maybe them putting out some new therapies to help with that. So, well, I'd like to thank everybody for listening to my presentation. Any feedback I could get would be great. Any other topics, I'm more than game to hear. I'm assuming that this type of webinar will be given again in the future. So, and there's my puppy again. So.
The puppy's much cuter than me. I'd rather have the puppy up right now, Evan. There's a couple questions that came up as you presented. One of them was, can dopamine cause issues with eyesight?
I think that I did see some stuff in the literature about it possibly causing some blurred vision. I have the monograph right here. I'd have to double check for sure. I think that there was also some issues, I think, in glaucoma patients in regards to taking dopamine. I think that had to do with some of the sympathetic outflow of dopamine and how it plays with that. Because in a glaucoma patient, intraocular pressure inside the eye, and if dopamine can affect blood pressure, it can also kind of affect that type of thing. Hopefully that kind of answers it.
But that helps. Another question that came up, is there a maximum dosage for SINEMET?
That's a good question. They do say the max dose is right around 200 milligrams of carbidopa and around 2,000 milligrams of levodopa per day. I don't know how well providers are actually kind of monitoring to keep that. And again, it kind of goes down to that risk benefit. When you go higher than that maximum dose, are you running more risk for side effects, or are you running more, or is there more of a benefit that the patient's actually seeing? Because if they go higher than that maximum dose, but they're not really seeing much of an effect, you might as well just, go back or try one of the different therapies to add on.
Okay. Another SINEMET question, and you kind of touched on it during your presentation, was can you maybe just delve a little more deeper into how protein affects the absorption of SINEMET?
Mm-hmm. Yeah, so the food that gets absorbed from the gut, a lot of those medications or the food that gets absorbed have proteins in them, right? And a lot of these proteins have amino acids, which are the individual components that make up the protein. So some of the amino acids get kind of converted into the, neurotransmitters like dopamine, norepinephrine, epinephrine. So I think that there's a competing strategy there that can kind of impact that.
Okay. Couple more, quick questions. Won't keep you too long. You want to go play with that puppy, I'm sure. Is there anything that you know of that can help with cramping in my feet? And I'm not sure if they're maybe talking about dystonia or just regular cramping.
I would say if it's not responding to like Parkinson's therapies, like dopamine related therapies, one thing that you could also look at is magnesium levels too. I know that they've used magnesium for like cramps. At the risk of it can cause loose stools as a side effect, but some people I've seen patients get helped with that, a reacted type magnesium.
Okay. And then one of the last questions that was posted, and this may be beyond what you know, but how much does viral gene therapy cost?
I'm assuming it's astronomical.
Yeah.
It's in clinical trials right now. So you can, if you're looking at that as an option, there's, I think on the Parkinson's.org webpage, which by the way, that's a great resource. I pretty much put together most of this presentation from Parkinson's.org. They have information on clinical trials that are currently going on. And sometimes with clinical trials, you almost get paid to be a applicant in a clinical trial, so that way they can test those things, or you're able to get newer treatments that before they come to market. But again, at the risk of, you don't know what the side effects are of those experimental therapies, and there's a risk there. So.
And I would plug too, Michael J. Fox Foundation has the Fox Trial Finder that you can register there. And what they will do is they'll let you know about any clinical studies that are going on, whether it's gene therapy. A lot of their studies with COVID right now, they've been able to do at-home things, just how are your symptoms and, some tracking. So there's a lot of options out there. Just look for them and then find out what you can possibly do. Mm-hmm. The last question I have for you, I've been with WPA for 7 years, and the number one request I get is, can we have a pharmacist come to our support group? And we realize with 200 support groups and exercise groups, it's really hard to get a pharmacist to go to all of them. So we're glad you joined us, even though Pat told you it was going to be 10 people. I think the biggest thing people want to know from a pharmacist is, what is your role when they bring in a new prescription? What are you doing to make sure that there aren't some of those interactions that you talked about on one of your last slides?
Yeah. So basically when I get a new prescription, what I'm doing is I get the prescription, I check it for the dosage at an appropriate dose. I check for the drug interactions and whether that is via computer program or just from my own educational knowledge of just what other medications is that patient on. So I check that, basically look at that as, is this medication appropriate for the patient? I'm also looking at if there's anything that's duplicating, or if there's anything that could have been anything else that could be added into the patient's profile to be helping with their therapy. So I guess in Parkinson's disease, if I got a prescription for SINEMET dosing and I noticed, hey, this is the extended release form of the drug, and it's being prescribed at the immediate release dosing frequency. So then I have to call the provider and get that switched to the appropriate thing. So you can use your pharmacist as resources. They have all the knowledge, and they're probably the most accessible person that you can have. And, they can always kind of help you or research and answer. I'll be honest with you. I might not have as much knowledge about Parkinson's disease as Dr. Manjan does. I thought her presentation was very informative and great. But I think that where your local pharmacist could help you is, they can research what questions you have and provide you with a logical answer, and then you can take it to the next step, or they can contact your provider with recommendations. So,
and I appreciate that, Evan, because I think a lot of us are afraid to ask our pharmacists some of those in-depth questions. And I think you just gave everybody permission to ask either you or any other pharmacist they work with. Really ask those questions and make sure you get answers that help you with your treatment.
Mm-hmm. Absolutely.
The last question that was just handed to me, because you mentioned magnesium. Somebody asked how much magnesium per day should they be taking if they're having cramping. I'm going to guess that's a question that you need to ask your pharmacist or your physician, but I'll let you take that.
Yeah, I think most forms of it come in the 400 to 500 milligram range. The thing is that I tell people is probably start there and see how that works. And just kind of monitor for that side effect of loose stools, because a lot of the over-the-counter medications to treat constipation contain magnesium, so like magnesium citrate. So I would just probably start there. And again, that might be something too that you should kind of run by your doctor first, because magnesium's an electrolyte. You would want to, like, if you had heart issues, you don't want to mess with EKG abnormalities due to increased in magnesium electrolytes. Be pretty rare, but still something to kind of run by the doc.
Well, I think that's important, Evan, is any supplement you take, including medical marijuana that you mentioned earlier, you should probably run past your physician to make sure that they're not prescribing anything that may counteract what's in those supplements, correct?
Absolutely. Yeah. And the other thing too, while we're talking supplements, is that you really want to make sure you're buying a quality supplement, because the supplements there's a lot of supplements out there that don't contain what they say they do, and they don't meet the quality criteria necessary. So the USP, the United States Pharmacopoeia, if you can ever find that on a supplement, it basically guarantees quality of the supplement and that it contains what it does.
I think that's a great way to end it. Thank you, Evan, so much for your time. I'm sure it was a great presentation. I've seen a lot of positive feedback that people very much enjoyed it. What we're going to do for the people online right now is we will take about a 10-minute break. Evan and Dr. Manjan have both mentioned a bunch of the pharmaceutical companies that we have as exhibitors today. Please click on the button and go meet with them. It asks you to share video and audio. If you don't feel comfortable sharing your video, you don't have to. You can still share audio and ask them questions. Or just like the presentation, you can go into each room and use the chat feature and ask them questions. They are sitting there waiting to talk to you, and we'll answer some of the questions that have come up today. So please give them your time between now and 11 o'clock. At 11 o'clock, we will start promptly with Emily Devine, who will talk about fall prevention and exercise, both very important things while we are spending more time at home right now. But so far, let's give Evan a round of applause. I'm sure we can all hear it. Thank you so much, Evan. And then let's take a short break.
All right. Thank you.